First, a few reminders. During the call, please mute your line so that any background noise and conversations will not become part of this recorded presentation. The mute feature is located in the lower left corner of the window. We will reserve time at the end of the presentation for questions and comments. To ask a question, you can either unmute yourself or type your questions into the chat box. The presenters will do their best to address all the questions at the end of the presentation. To help us track attendance, please put your name and organization in the chat box. If you're on the phone, please email your name and organization to me at guthriemoss@wisc.edu. That's GUTHRIEMOSS@WISC.edu. A recording of this presentation will be available on the Health Transition Wisconsin website. And at the end of the call today, please complete the evaluation at the link provided in the chat box, and we'll copy that several times. Slide 3, please. If you must leave early, please complete the evaluation before logging off. Our presentation today is on strategies and lessons learned for engaging youth with complex health conditions who are transitioning to the adult healthcare system and their families during COVID-19 and beyond. We are very excited to have two presenters today, Brandy Midauer-Oxler, who is a doctorally prepared nurse practitioner and a Cystic Fibrosis Transition Program Coordinator at the Children's Healthcare of Atlanta and Emory University Cystic Fibrosis Care Center. And Megan Teed, who is a doctorally prepared nurse practitioner in the Complex Care Program at Children's Wisconsin. Thank you, Brandy and Megan, for joining us, and let's get started.
All right, well, thank you, Beth, so much. Can you guys hear me okay?
Yes.
Yes, I hear nodding good. Well, as she said, I am here to talk to you about my experience with transition in our transition program on the next slide. I just have one disclosure. I do receive compensation for being a trainer for the Partnership Enhancement Program with the CF Foundation and the Association of Communication in Healthcare. On the next slide here, our talking points today. I'm going to describe our model transition program at my location, discuss some adaptations that we made during the pandemic, and then also apply lessons that we've learned and how we're going to carry those forward into the future. And on the next slide, I like to start by getting a little real with everybody because I'm a researcher, I'm a nurse practitioner, I'm also the parent of several young adults. I'm getting real because in several of these slides I have no makeup on as well. So a lot of my practice has occurred because of my experience. It started as an inpatient nurse at a Midwestern hospital that did not have a transition program. I experienced a lot of emotions and fears, seeing some of our young adults in their early 20s showing up honestly on death's door because they were afraid to go to adult care. And it really made me question, what can we do better for these people? How can we support not only our young adults, but our staff, our parents during transition? And then during that time, I got my doctorate. I focused on transition while my young people in my life were growing up and learning how to manage all of their own chronic conditions as well. So I'm very proud of the young people I have mentioned here and have their pictures. My oldest two boys are in their 20s now, doing a great job managing their chronic conditions and just doing amazingly. My youngest here on the lower left-hand corner is a senior. She's doing fantastic as well. And I think all of us as parents and as providers really just hope to make it to the point in our lives where our young adults are managing their disease and still hopefully having a great relationship with us, where they can come to their support people for advice, for what they need at any time in their life. So, well, enough about me. So on the next slide, I want to talk a little bit about how CF is like other chronic diseases. It's diagnosed in infancy. It can impact the whole family. There's lots of literature that shows the stress and the impact on the whole family for a chronic disease. Our disease for CF requires multidisciplinary care. Typically our patients are seen 4 times a year, both by pulmonologists and often by other physicians as well, because it is a multi-organ disease. This really requires lifelong management as the diagnosis does not go away, and it's carried into adulthood. So one surprise I wanted to share with people, especially if you're an older nurse like I am, who has experience with a lot of people with cystic fibrosis not living to adulthood, is that there have been huge strides made in our medication management over the last 20 years, and especially in the last 5 years with some of our new genetic modifier drugs. Now the median survival for people with cystic fibrosis is over 46 years of age. And for the first time, there are more adults with cystic fibrosis than there are with children. And so it's really gone from what used to be almost a palliative care approach, make that child comfortable, make them happy, let their parents take care of them, to one where we need to help encourage our young people to manage their own disease and become adults that are productive and reach their full potential. So I just wanted to share that and for you to keep in mind before we talk about our transition model. So on the next slide, I also need to talk about how CF might be different from other diseases. And there are a few ways that you might need to keep in your head as I talk about our transition program. And really the first one is our infection control policy. So it is recommended that we use contact precautions with all of our patients. And that means gowning and gloving and keeping all of our people with CF over 6 feet apart. Since you're living in the pandemic, you know the burden that causes and sometimes the isolation as well. And our patients, about a quarter of them, 21 to 24%, have depression and anxiety in the age of 12 and over. Another thing that might be different is the complicated medication regimen. A lot of our patients do 1 to 2 hours of airway clearance. You see one of my patients here in his vest. He'll do that for 1 to 2 hours a day when well, let alone when sick, as well as inhaled medications. And it is a multi-organ disease. I know a lot of people think about the lungs being affected with cystic fibrosis, but it also affects the GI tract, which means that some of our patients have ileuses and obstructions and have to see GI specialists. A good portion of our patients as adults have cystic fibrosis related diabetes, which is managed with insulin. So they're a lot like type 1 diabetics on top of having cystic fibrosis. And then there is a high treatment burden and a complicated medication regimen. My closest friend's son has cystic fibrosis. This is a picture of him in the upper right-hand corner when he was about 5 years old. And those are all the medications that he would take that day. So medications are taken throughout the day. The majority of our patients, about 80%, are pancreatic insufficient, which means that they have to take pancreatic enzymes with every meal. So you'll see when I talk about our transition program that there is a lot of education about medicine, and that is just because of the huge medication load that our patients have. One other thing I should mention is that most of our males have the absence of the vas deferens, which also impacts fertility. And so I don't talk about it a lot in this talk, but we do quite a bit of education on genetics and fertility and how they might want to have children someday. And that's based on findings that we found in our surveys of that's what young people want to know about. It's honestly one of the first things they ask when we're alone in the room. One other thing, besides having cystic fibrosis, my patient population has a lot of other diseases as well. So we have the average incidence of autism. We have other chronic diseases. I have one patient that has sickle cell, childhood cancers, sometimes cognitive disabilities as well. So there's a lot of individualization that needs to occur in our transition program as well. So on the next slide, I did want to touch on just real quickly, who are the participants in transition? So it's obviously the medical team, which may vary on how many medical teams are involved in care. The adolescent, of course, being the patient, as well as the family unit too. And this really can vary depending on who is supporting that young adult during transition. So sometimes we find that it's more grandparents or guardians, we have foster parents, but a lot of times siblings and other friends and peers are quite influential to our young adults. And so we really welcome during visits that they bring those people with them. If they're dating someone or become engaged, we invite them into medical appointments as well, because I found that that can really help support the young adult during transition time too. So most of the time today, I'm going to talk about some of our interventions in our transition program that obviously will impact the adolescent the most. And I'll talk about a couple of ways that we are helping to try to support the family as well. All right, on the next slide. So now finally, it's time for me to talk about our transition program at our care center. The name of it is The Journey to Independence. And it was written by our child life specialist and our social worker long before I ever came to our team. And it came into existence in 2006, which to me is really remarkable considering the landmark recommendation from the American Academy of Pediatrics and other organizations really was in 2002. So in 4 short years, they went from a recommendation to having a transition program. So at the time our transition program was written, it was written to go down to the age of 8, but because of staff constraints, it started at the age of 16. And then just recently when I joined the team, we added some of the modules down to the age of 10. So at the moment, we start transition activities at age 10. We have another transition activity at age 12. And then we really ramp up the education at age 15. And at 15, it starts at every clinic appointment, which usually is 4 times a year. So our transition program is broken down into some knowledge assessments, some education, and then we've also identified some important tasks that are needed in adult care as well. So on the next slide, I really want to talk about a way that I think a lot of us may struggle to find terms about how to transfer skills from a teenager over from an adult. And we have a very successful way to transfer skills to teens across the board, and that's how we teach teens how to drive. And for me, without a transition program, it's like having a teen that has never driven before and thinking that they will know how to be a great driver just because they have been a passenger in a car. Now, doesn't it sound crazy to look at a teenager and think, hey, you've never driven. Let me toss you the keys, ask you to drive down the highway and parallel park in front of a sports complex. I mean, it is never going to happen. It's going to be a disaster. And to me, that's exactly what it's like, thinking that because of our teenagers have been in medical appointments, that they are going to magically be able to be an adult functioning in adult care. So just how we are able to get the parent out of the driver's seat and put the teenager in the driver's seat and create a safe environment for the teen to learn small chunks of skills and then assess their safety, assess their knowledge, and gradually get more confident and gradually get more difficult. To me, that's just what a transition program is. And I like to give this, thank you so much for the great analogy, I appreciate that. I love to give this analogy to other people, especially if you are struggling to have solo visits. And I know many people out there are. When I describe it like this, I'm able to get a lot of parents to understand how important it is to put the teenagers in the driver's seat. All right, on the next slide. So here is a couple of our modules, a couple of our stages of our transition program. This is the trail guide and the deputy stage, which kind of goes along with our journey to independence. And what I haven't mentioned is that I am not the only person doing education and doing tasks with our young adults. It really is carried out throughout our multidisciplinary team. A lot of it is done with our respiratory therapists, our social work, our providers, our nurses, our pharmacists. And it really makes a great way to support the team across our multidisciplinary team. So you'll see here, we have some educational objectives. Here it's called homework. A lot of these activities actually are in the room with the patient, and they typically only take about 10 or 15 minutes. And it really goes across understanding a lot of their respiratory treatment, understanding their medication, really knowing how important nutrition is for cystic fibrosis. The better your nutrition is, typically the better your lung health. There have been lots of studies that show that. And so we really try to arm our young adults with knowledge about that. And understanding lifestyle. So we also get I'm lucky enough to have gifts to give to our young adults. Sometimes it's as simple as a water bottle or a backpack. But they seem to really appreciate having fun things to take home at the end of their stay. And on the next slide. Before I get into some of the specific activities that we use, I wanted to offer this model. It is from the CF RISE, and I've listed the website in my works cited. But I think this does a really great job of illustrating the slow progression of young adults taking over tasks and understanding from their parents. And to me, when I see write-ups and information about transition programs that happen in one day, I honestly sometimes have a problem with it, because a transition program is really so much more and takes place over time. So it really starts with the adults in their lives, really providing and teaching and managing most of the healthcare decisions. And then slowly over time, it changing to the young adult who really starts leaning and owning their own decisions themselves. All right, on the next slide. So here are two of our transition activities. These are knowledge assessments for the most part. On the left, you'll see what I call it my med sheet. And it really describes, it helps the patient list out their medications, the names of it, what they look like, how much they should take, and how often they should take it. And why we go over this with our patients, again, is because of their huge medication load. I noticed early in my career that I was having people with CF saying, I don't know, I take that pink pill. And it really was evident to me that they needed a little bit of education on the importance of knowing what they were taking. That way, if they were ever inpatient, then someone tried to give them the incorrect medication, they could say, yeah, I don't take that. On top of that, we also try to help the young adult learn and know what the medication is for. One time I had a young adult that was really struggling with their compliance and their daily care. And I asked her what was the hardest part of her day. And she said, my day is so tough because I've got this thick mucus inside my lungs and I can't get anything to get it out. And I said, what would you think if you had an inhaled medication that went in like little ninjas and chopped up your mucus? And she said, I'd take it every day. And I said, you have Pulmozyme, and guess what? That's what your Pulmozyme does. And from that day on, I don't think she ever missed another dose. So sometimes understanding the reason and the purpose for the medications can really help them be more successful in their daily care. The activity on the right we have is understanding CF in your own words. This is one activity that actually can be done outpatient or inpatient. And it really asks some of our young adults to describe really in any way they want to how CF impacts their lives. So we have had here a couple of the pictures that have been drawn by some of our young adults. I've had paintings. I have a young adult who actually had a book of poetry published, and most of it is about their cystic fibrosis. And it has been a really instrumental way that especially some of our more introverted patients can share with us how CF impacts their lives. All right, on the next slide. Oh, Tim, can you go forward for me, please? Thank you. So on this slide, again, we talk about few important tasks. One of them is having solo visits. It's something that we advocate for. This is being tracked and monitored nationally, especially for children with special healthcare needs. And I'm happy in our state that the number of people having solo time alone with their provider has gone up for every year since I have been in Georgia. The other one is a checklist. And on this checklist that we've developed, we ask the teenager to have a version of this and the parent to have a version. And they really self-rate, or the parent rates how they're doing and taking over those really important skills for adult care. And the interesting thing is that there usually is great similarity in how the parents are rating their young adults and how the young adult self-rates themselves. And I also try to make this a time to really point out the strides that they've made, how far they've come, how well they're doing in managing their own care, and then really trying to work together to see where they want to move to more independence next. And I think having that positivity can also really help young adults. Going back to my driver's ed analogy, we expect new drivers to curb check every now and then. We don't expect them to get in the car and be able to drive correctly the first time. And so I think having that knowledge and being really open with them about that and saying, I don't expect perfection. I just expect you to try, and we're going to work together, and hopefully you're going to grow. Helps having this growth mindset for young adults. So on the next slide, I do want to talk a little bit about an inpatient initiative that we had in one of our 2 pediatric hospitals. The patient population here in Georgia, we have an incredibly large CF group. We have about 350 pediatric patients and over 400 adult patients with cystic fibrosis. Among our pediatric program, they actually are admitted to 2 different hospitals in 2 different areas of Atlanta. And at one area of Atlanta, our nurse scientist had an idea on how to help our adolescents be more autonomous. And so she wrote and came up with a way to make a limited scope policy that our adolescents would be allowed to keep their enzymes in their room in a locked safe, instead of having to call for the nurses every single time that they wanted to eat. So with every meal and snack, they have to take these enzymes. Nurses, of course, have other tasks. And sometimes if you are doing a lumbar puncture, or if you are doing something really high risk with a patient, carrying someone's enzymes might have to wait 15 minutes, which was incredibly annoying to our patients. It didn't make our nurses feel great either. And so with this limited scope policy, we actually are able to have patients keep their medication in the room, only enzymes for right now. But the increased satisfaction between our patients, our parents, and our nurses has been amazing. It has also been a great way for our CF team to see who easily takes their enzymes and who sometimes needs reminding, which gives us a little bit of clarity about what may be happening in their home life as well, and trying to really problem solve ways to help them remember to take their enzymes. So if you'd like to read more about this, I've got the citation down below. There was a manuscript that came out this year, but I am proud that we are able to help some of our young adults be more autonomous in this way. On the next slide. We also do have some support for parents. I have to be honest, I think this is an area we need to focus on even more. And part of it is just having the lack of staff and having the lack of time and not being reimbursed for the time that we spend with parents, which is unfortunate. But we do have a family advisory council at our hospital, and thankfully, we have a CF advisory council as well that is only made up of parents and guardians and grandparents that are caregivers to children with CF in our area. And they really help look at all of our transition activities and give me input whenever I'm thinking of making changes. They've really helped show the importance of shared goal setting with our patients and really having clear communication on expectations, especially when we're going to try new things. And I appreciate all of that input and try to incorporate it in my practice. One other support that we do have that has been new in the last year is a parent support group called the Breathing Room, which is a virtual CF caregiver support group. It's facilitated by our mental health coordinator, Shayna Blair, who is amazing and does a lot of national work for the CF Foundation. So once a month, parents meet in the Breathing Room in this virtual support group to really give support to each other, to have a therapeutic place where they can really talk about where they are struggling or where they're doing really well with CF and offer each other support. And it's great to have Shayna there because she can sometimes offer ideas that really could help improve relationships or that might be age appropriate for their loved one with CF. When this support group first came about, we really thought that it would be for new diagnosis. A lot of parents struggle and really grapple with guilt and the regimen of care that comes with CF. But about a year ago, Shayna opened up the support group to include transition age parents. And even after your loved one moves on to adult care, the parent can stay for an extra 12 months. And really quickly, the majority of participants became parents of transition age people. And so it really was an eye-opener to us that parents need support during this time. And I'm happy that this is one way that we can try to provide that as well. On the next slide, I do want to talk a little bit about the last pediatric appointment that we have in pediatric care. I often call this our graduation clinic or a capstone clinic. And we are incredibly lucky to have an adult cystic fibrosis center that is just a few blocks away. I am actually, even though I work at our pediatric hospital, I am funded by Emory University. And I work both in pediatric and adult care. About 80% of my time is in pediatrics and 20% with our adult team. So our adult team physically comes to the last appointment. We actually have either a breakfast or a lunch where we really present the patients to the adult team, talk through their medical history, which can be complex, but also give a really personal view of what our patients love and what they're interested in and what their hopes and dreams are to try to really individualize who they are. And then we go down and meet the patients, and the pediatric providers introduce the adult providers. The respiratory therapists introduce the new respiratory therapists, and so on down the line for our multidisciplinary team. I prepare a packet of information on the adult team for our patients. That also includes how to get to the new CF clinic, where they would be if they needed to go for an inpatient stay, which is Emory University Hospital. I give the location, where to park, everything. Also, we're lucky enough that we have an adult family advisory council that have put together a list of the most common questions and answers about moving to adult care. And then I also have a bio of the adult team with pictures and contact information. And I have, the places you'll go, the hardback by Dr. Seuss, that our pediatric team, both inpatient and outpatient, signs. Often they'll put in pictures that they have of themselves with the patient over the years. And I think it's a really good way for our pediatric team to really process the fact that they're leaving and say any important words of encouragement that are really healthy for them to say. So on the next page, here's an example of the welcome letter from the social worker. Here's the example as well of the Emory Adult CF team. And we tried to get pictures where everyone is smiling and looking welcoming, which I think is important. And I talked about the frequently asked questions. There's just a little blip of it so that you can see what it looks like. On the welcome letter from the social worker is their contact number, which is bolded 3 different times because we really want them to have the contact information for when they move to adult care. I also make it very clear that although they're only required to be seen quarterly, that we would like them to follow up in adult care within the next 6 weeks. And a lot of times the adult providers will come with an appointment slot held for them. That way they can find out about it that day. So I closely watch who is showing up in adult care. I'm in pre-clinic for our adult team as well as our pediatric team. And then, so the next appointment when they have in adult care, I'm there to answer any questions for the adult team if they have it as well. And then on the next slide. So I do quickly want to talk about barriers to transition. It would be remiss of me to act like these don't exist, but there are staff barriers to transition. Some of those include embracing transition as positive and necessary. And I think one of the ways we have to watch doing this in pediatric care, I've heard people innocently saying and well-meaningly, oh, I can't believe you're going to adult care. Why do you want to go there? And to me, this is a mistake. We would never look at someone on their high school graduation and say, oh, college, why would you want to go to college? Your mom's not going to do your laundry. She's not going to cook for you anymore. So to me, I think we have to be really careful how we talk about adult care. I am very real about adult care. I don't want to not talk about the pitfalls or how it is very different from pediatric care. But I think we have to be positive as well. I try to tell the young adults that you are going to run into times in your life where you don't have the right answer or you're unsure what to do. And all you need to know is what your resources are in adult care to help you out. So to, again, try to have that problem solving mindset. So there are patient barriers as well. And a lot of it has to do in the literature about leaving their trusted pediatric providers, which is one of the reasons I think meeting the adult team can help have a friendly face as well. And then of course there's system barriers. And I come across a lot of these in my daily activities. And some of that includes how to track transition and also how to be reimbursed for transition. It's difficult for us. We typically in CF are coding at the highest levels. And so I do not get reimbursed for any of the education that I do that takes part in a normal clinic visit. And sometimes it's hard to justify then why I'm even there. On the next page. So I'm going to talk a little bit about some of the adaptations that we've made during COVID-19. Now that you have a clear understanding of what our traditional transition clinic looks like. So like everyone else, we had to pivot to telehealth during the spring and summer of 2020. Our clinics were closed for up to 2 months, and that was difficult for our patients. And luckily, our adult team pivoted really in about 2 weeks to telehealth, which was a huge help for our adults. And soon after, we did in pediatric care as well. I know our patients incredibly well. I mean, now that you can see, I meet with them several times a year. I know their transition wishes. I've been listening to them for a long time. And it was really surprising to me that during the pandemic, when I was reaching out by phone or by email or through the electronic medical record to our young adults saying, hey, you know, what are you thinking about transition? A lot of their longstanding wishes and plans had completely changed. And it was a huge shock to me. People that had wanted to move to adult care were voicing concerns to me about, you know, Brandy, I'm afraid there's more COVID in adult care. And if I move to adult care, I'm afraid that that's going to be a problem. And so they wanted to stay in pediatric care. Previously, people that had wanted to stay in pediatric care all of a sudden felt very confident in the doctors that were on the news taking care of our COVID patients. And so some people actually wanted to move to adult care more quickly, which again was a surprise to me. And they were really using sound logic. Our young adults were in tune with what was right for them. And they had these preferences that I really wanted to honor. And so some of them even said to me, I'm almost confused about why I've changed my mind, but yet I feel this way. So for our patients that wanted to stay in pediatric care, I went to our institution and asked for an exception. At our location, patients cannot stay in pediatric care past their 22nd birthday, and they made an exception to allow people to stay if that's what they wanted to do. Next page, please. And so we had a capstone clinic. We had that graduation clinic for those that wanted to transition during the pandemic once our clinics were open again. The biggest caveat is that Emory would not allow our adult team to come over in person. It would break the number of team members that we could have in one place. And I understood that. So really quickly, we pivoted to telehealth, where our pediatric patients were present, our pediatric team was present, but our adult team came in through telehealth. And it had actually some positives. So when I met our patients that day, I was gowned and gloved. I had my mask on. I had goggles and a face shield on, and they really couldn't see my face. But it became quickly apparent to me that Dr. Hunt, our adult pulmonologist that I was holding on an iPad, was sitting there with a shirt on and a big smile, and our patients could see how friendly he was. And so it became a really nice way for our patients to have a few less barriers, even though they were on a telehealth visit. I do want to say that we had one patient that moved to adult care that is on the spectrum, and she especially said that it was helpful. She said it's very hard for her to have conversations with people when the only facial cue she can see is their eyes. And she said how refreshing it was to see the adult team in their whole face. So another adaptation we've made during this time is having our genetics and fertility module be available through in-person visits with our genetic counselor. I think especially these types of conversations, which are very real, it is great for them to see our genetic counselor's entire face when she's delivering and having these conversations. And if you're interested to hear more about that there is a write-up on that as well, and I've listed the paper. Oops, sorry, there it is. And that was published earlier this year as well. And next slide. So lastly, our lessons learned. For me, it really was the importance of communication, especially in times of uncertainty or crisis, and to really acknowledge the problem-solving skills and even praise it in our young adults. They are using those skills for the first few times. They were a little uncertain about whether they should be doing it, but honestly, to me, that is really the highest praise and the highest thing that we can ask of our young adults, is that they are looking at what's right for them and they are telling a medical team what would suit them. And then for me, it was advocating for their preferences to my institution and with our adult team, and really to find a way to pivot to telehealth. Which in the end really reduced barriers for my patients and for the team. So now for the summer of 2021, we have transition dates set, 2 for May and 1 for July, for about 35 young adults that'll be moving to adult care. And we're thinking it's going to be a mix of telehealth, probably with the adult pulmonologist there in person, but the rest of the team available on iPad. And I'm hoping to get some measures that way we can track what our patients and our families think of that as well. And for me, during this time, during the pandemic, that transition group that we had last year had a little bit more trouble than typically they do following up in adult care, actually showing up for that first appointment. So for me, it's also understanding that during a pandemic, when things are uncertain, to make sure that we're offering support and also making sure that they follow up in adult care. And I think that is the end. Thank you.
Right, thank you very much, Brandy. Brandy will be taking questions at the end. Let's go ahead and hear from Megan Teague.
Before I get started, I just want to say, Brandy, that was an amazing presentation, and thank you so much for sharing all of your experiences, both pre and during the pandemic. So today I hope to share just a little bit about our experiences in the complex care program at Children's Wisconsin and some of the challenges that we've experienced and questions we're asking ourselves at this point. Next slide. So a little bit about our program before we get started. So we are a care coordination and medical co-management program. So we see kids who are followed by at least 3 specialists. Most of them have many more than that. And we help to coordinate their care, work with the specialty providers. And now a big aspect of what we do for our young adults is help with transition planning. So I would say kind of the state of our transition within the complex care program, mixed practices were really happening until 2019 when we had our QI grant looking at how to safely transition kids with medical complexity. And so in 2019, we really started having more of a systematic approach within our department, starting transition conversations at the age of 12. And we see our patients every 6 months in clinic. So every 6 months, we would have at least a brief segment of our clinic visit, which is typically an hour in length, devoted to talking about transition. And really between 12 and 14, it's just getting them comfortable with talking about transition. Because a lot of families, that first visit where you talk about transition, it's deer in the headlights, anxiety, and even some comments of, well, I thought I could stay here forever. And so a lot of it is just kind of that reassurance and, dipping your toe into the water besides, waiting until closer to 17, 18, where it's a mad dash trying to get everything done. But some of the things that we were implementing was, how can we have pre-anticipatory guidance for our families in their after visit summary? So they have just kind of some takeaways from the visit, and started to chart more transition plans in the note. So our notes have a chart that's split up into every specialist the patient sees, kind of what the plan is, who the provider is. And now we've added a transition column. So we specifically, you can kind of go down each row and see, okay, pulmonary is going to keep them until 21, and this is their transition plan. GI is going to discharge around 18. This is their transition plan. Just so it's kind of a one place that people can look and see what every specialty is doing. And I would say pre-pandemic, we had the luxury of, if we were in clinic and needed something, we could page our social work colleagues. We could call people, have them come into the clinic room, and really help with some of these conversations if we needed to. Next slide. And then the pandemic happened. So March was a little bit of chaos. I think asking ourselves, we have to stop transition talks, right? How much do we talk about? How do we answer questions? We had momentum leading up to, I would say, March of 2020. Now what? And so I would say most people in our program really stopped talking about transition between March and April, just while we were trying to figure out telehealth. And I would say we were lucky enough that our program, within 2 weeks of closing clinics, if we didn't have access to video visits, we were doing telephone visits, of really trying to have that communication happening so we can not only reassure our families and answer their questions about the pandemic, even though we didn't have many answers at that time since it was so new, but also, providing that reassurance and helping them with their medical needs that, none of them stopped when the pandemic started. They're always ongoing. Some of the challenges once we started talking about transition again was our adult healthcare systems. They were burdened by increasing COVID cases, especially the acute care systems, limited clinics, both in the adult and pediatric world, the anxiety component, both families, but I think you could probably mention that staff had a degree of anxiety just given the uncertainty around everything. And I think one of the concerns we had around April was, we knew that this was not going to be a short thing. The pandemic wasn't going away anytime soon. And what happens to those families that were struggling so much with coming to grips that their young adult would someday transition? And let's say it's a year, it's a year later. What happens when we say, okay, well, now it's okay to talk about transition again? Are we starting again from the beginning? Next slide. So I would say we were lucky enough that, I would say by May, we were talking transition again and kind of going back to the conversations and the format that we were having in clinic prior to the pandemic. The majority of our visits at this point are still virtual. We are seeing patients in clinic, but for the most part, we're allowing the families to make that decision of where they're most comfortable. From a care coordination standpoint, we're lucky enough, we can do a lot of our work virtually. But I think the complicated part becomes that physical exam and some of the cues of reading the room. You know, if I was having a conversation with a parent who was maybe a little more nervous, maybe I would see their toe tapping a little bit. Maybe I would see, you know, they wouldn't be looking at me, or they would maybe be a little more frenetic in clinic. You can't necessarily see that during a virtual visit. So there were some challenges that way of trying to see on a screen, how are people handling this? Our after visit summaries in our note, while they can see components of that in my chart, or we can add an addition through that. So they have an electronic version. Many of our families still want to have a hard copy. So we do continue to print them and mail them for the families that want that. Some of the conversations we're currently having are there certain seasons and times that we have to delay transition? For a lot of our population, they have either a component of respiratory illnesses or some degree of being immunocompromised. And so maybe winter is not the best time for most people to transition. Now, that being said, there are some patients that if everything is teed up and ready to go, it could actually be more of a safety issue trying to hold them back, just given the state of the pandemic. So everything really depended on each individual patient and situation. Some of the other challenges we had were barriers with some of our families who have low socioeconomic status or that were non-English speaking. You know, many of our patients could quick jump onto telehealth visits and video visits, but some may not have good Wi-Fi. They may not have a phone or a computer that works. For our non-English speaking population, how do you get an interpreter on? And depending on the language, some of those nonverbal cues are so important. So for a while, the bulk of those patients we were seeing in clinic just to try to get an in-person interpreter and have that as a resource. I talked a little bit about the safe time to transition, but some of the other conversations were the fiscal implications. The pediatric healthcare system is struggling during this time. And so do we push transition during this time from a fiscal standpoint? Something to consider, but at the end of the day, you have to do what's right for the patient and the family. Next slide. And so some conclusions and questions that I feel like we're still investigating. Well, there are certain times where transition conversations can be halted. You know, if a child or a young adult is not doing well, is acutely ill, that's probably not the best time. But I think the beginning of the pandemic and all of those uncertainties, I think it was fair for us to say, okay, it's important, but it's not top of the list. Having those resources, both in electronic and paper copies, I think has been crucial for our population. And really, like Brandy mentioned earlier, communication, making sure that it's frequent, that it's clear, and that really everyone is on the same page. So I think some of the questions I'm currently thinking about is virtual versus in-person are both needed to safely transition our population. I think there is a degree that it's true, we need to see them in person, but how do you make families comfortable with that? How do we address lack of resources for different populations, whether it's low economic status, non-English speaking, or even certain diagnoses? And at the end of the day, how do we create a visual tool for our families to provide some of that pre-anticipatory guidance, and so they can see where they are in the transition path? I think some of the tools we have in our electronic medical record, they may fit the healthcare provider and the medical role, but it's not as family friendly, or it looks like just another piece of paper. So how do you have it in a way that people have easy access to it, that's a little more inviting and welcoming? And that's it.
All right. Thank you so much, Megan. And Thank you, Brandy. I just wanted to say that I am so impressed with the fact that both of you talked about best practice and the idea of forming relationships with the family. I know, Megan, you were talking about watching that toe tapping on the floor, and Brandy, the idea of looking at the whole person, the whole patient, the whole family. I think that patients and families have, they're very fortunate to have you all in their lives. So I did want to open us up to questions. Would anyone like to speak up with a question, or let's see, let me see in the chat here. Whoops. Let's see, we have the same policy of at the UNC hospital, and I think that was allowing the patients to have their medications in the room with them. I believe that was what that comment was about.
It may have been that, or it may have been the transition age policy. So,
okay. Tyra, do you?
Sure. Yeah. Hi. Great presentations all around. I have just enjoyed this hour of information. It's been amazing. And yeah, so at UNC Hospital, we do have a policy on the CF floors that patients can have their pancreatic enzymes. They can do that themselves, which helps out a lot.
Yes. Good.
Great, thank you. And then we had a comment, and actually this was for me, but I'm going to share it anyway, but about the packet of information. I've really not ever seen anything that's that complete and thorough. So I thought that was really impressive. So I did have a question for you, Brandy. When you were talking about the interdisciplinary team, how did you get everyone on board? Because I know Megan was talking about the GI. In GI, you transition at this age. In respiratory, you transition at this age. And so how did you get everybody on the same team?
I'm so lucky that our team values transition, and I think it comes from having our chief of pulmonary value transition. And so when it's top down, things are a lot easier. I advocated to our chief of pulmonary to make a transition coordinator job for me, and she did. So, so having the multidisciplinary team there is really part of our team practice. So every week we, 1 day a week, spend about 2 hours going over every patient that will be there for the upcoming week, both on the pediatric and the adult side. So I think it really goes along with our group practices that every time we have a patient that we've been together to discuss the patient. Now I have to say it's hard from a reimbursement standpoint because our adult team does not get reimbursed. And so it really is a labor of love that they absolutely do because they think it's best for them and it's best for the patients. So.
Oh, that's great.
Yeah.
That's beyond best practice.
Thank you.
Caring about people. Yeah. So does anyone have other questions? We have 5 more minutes. I have a couple, so I'm just
I have one also.
Oh, Julie, go ahead. Okay.
Hi, Brandy. Hi, Megan. Thank you both for an excellent presentation. Brandy, I really do love your driver's ed comparison. I have to agree with Lynn on that. That is a brilliant, brilliant comparison. I will keep that one in my toolkit. My question for you is, you mentioned a couple of times, as many of us know, not great reimbursement for the time spent on transition. You'd mentioned that you're funded kind of through Emory University, mostly through peds, and I think you said like 20% as adult. That being said, you do have a really impressive toolkit with your booklet, your even gifts that you give your kiddos as they're moving through that transition. How do you fund all of that? Is that all privately funded through your hospital system, or how are you funding that?
So to begin with, I had a 3-year startup from a private philanthropic foundation that starts new careers at Emory and Children's Healthcare. And so they funded about $300,000 worth of my work. And then Honestly, we struggle a little bit. During COVID, I was reduced from 1.0 to 0.8 to kind of make our money stretch a little bit further. And then to help bring in more money, our high-risk asthma was wanting a transition program as well as our trach vent. And so now I spend 10% of my time each week helping develop transition programs for them. And then I also do grants with the CF Foundation. I'm on part of some multi-site grants for palliative care and the pediatric and addressing distressing symptoms with our patients as well. So, and then you saw my disclosure about being a trainer for the Partnership Enhancement Program, and that's another reimbursement. So in some ways I get pieced out a little bit, all on things I love, but all really to help fund my position as well.
Great. I appreciate that information. I mean, we have a lot of amazing providers and practitioners that take part in our learning call, and we're always, I think every one of us is always looking for different ways that individuals are funding and granting, and where are people building these robust programs. So I think that's really helpful to kind of hear the meat and bones of that.
Thank you. I left out one. So I had another year of funding from our Children's Foundation through a private philanthropic grant called the Boomer Esiason Foundation. My funding is over, but a couple of my publications will be coming out, just really interviewing families about advanced lung disease, what they think about lung transplant, how they want to be approached about lung transplant. But again, it's all about how can you keep your funding. So I think if you work for a hospital that has a children's foundation that really engages with donors, letting them know what you're willing to do, or if they have ideas from donors that you're open to taking part in research that would suit the funding is another idea as well.
Great. Thank you. Really appreciate both of your time today and your expertise.
All right, well, we have one more minute. I have a quick one for you, Brandy. As far as internet access and for patients, it sounds like you've been doing a lot of telehealth. How are you managing that?
It's difficult, to be honest. So we're lucky that the CF Foundation sent out home spirometry to 80% of our high-risk patients to begin with. So it helps us from really a standpoint to know what their lung function is. But a lot of our patients do not have internet. They're coming from rural communities. They have to drive to get to a location where they have internet. And so some of our private foundations, and the CF Foundation was helping to come up with ways to pay for that. I think the one thing no one talked about or touched on is that if you have a family in a small home that's trying to have a private medical conversation, a lot of it can be overheard. And so I always start with asking our patients, are you alone? Are you somewhere you feel comfortable talking? And then sometimes you'll see people walk behind them, or you'll hear a fight with siblings go on in the same room. And it's like, okay, they may not be as private as I was hoping they would be. So I think there's internet problems, and I think there's also some privacy issues that can happen when having home telehealth appointments as well.
All right, well, thank you so much to Brandy and Megan. It is time now for us to break up, unfortunately. The information you gave us today will give all of us food for thought as we navigate this pandemic and implement best practices in transition. Please fill out the evaluation. The link is in the chat box. And we hope you'll join our next learning community on May 13th. Thank you for your participation. This concludes our presentation.
Thank you so much.
Thanks, everyone.
And I also put my email on there if anyone wants to contact me by email too.
Oh, great. Fortunately, we had someone just join us. I think they must have gone in a different time zone. That's too bad. But we are recording, and I'll send out the recording to everyone who signed, the link to everyone who signed up, and it will be on our website.
Great.
So Megan left, I believe, but Brandy, that was just so wonderful. Thank you.
That
Oh,
was
well, thank you.
excellent. You guys have an awesome program.
It was. I wanted to gush on, and I thought, oh no, we've got limited time. They don't want to hear me for 5
No, I feel so fortunate to have such institutional support. It is unusual for a nurse practitioner they basically let me set my own hours, and wherever I want to go, they let me go. So I am very thankful for being allowed to support people where I feel like I need to support them. So inpatient and outpatient, especially some of our patients with more advanced lung disease, which I haven't really talked on. Being able to be present when they're inpatient is really huge because they have a lot of time where they're digesting and want to speak. So,
yeah, great. Well, I will keep your name in my toolkit. I will keep your name in my search box. It sounds like you've got a couple more publications that will be making it out onto the wire.
I hope so. I've got one under review right now for the special transition issue of the Journal of Pediatric Nursing. So it's under a revision. It's some of our biggest work, and I really would love to get it out. So it's some survey data from our young adults that have moved on to adult care, what they said they liked about our transition program, and the changes we needed to make it better. So
awesome. Well, I'll look forward to that. Great.
So could you send me a list of your publications, and I can put those on the website with this,
Sure.
With the PowerPoint and everything, and then also send it out to everybody who registered. So because that's really where Tim and I saw you, and
which was amazing to me. You weren't there, I don't think, to hear me say it, but when we turned in the first paper on transition and COVID, Randy, who's our adult pulmonologist and the head of our adult center, just said, Brandy, I don't know if anyone's ever going to read this. And I said,
you missed that, Beth, when we did the original meet with Brandy. She told us, she's like, I'm just so happy someone read it.
Oh, he said 5 people might read this and that's it. And I said, well, maybe if it can help 5 people, we'll be okay with that. So when on our first meeting, when I literally almost fell out of my seat, and I thought, well, of course you read it, or you wouldn't even know who I am. It was just so great that it put us in contact together. So
well, and hey, you've got 30 more people who read your article today. So.
Well, it's strange. In the last month, over 700 people have read it, or the statistics on it. So yeah.
It's got far more interest than
than the 5 people I thought would read it. So
I mean, everyone's crying out for ideas, for how to handle everything. I mean, gosh, I
just got an invitation from another journal based on this one too. So I think at our next transition clinic this summer, we'll try to have some more data and possibly some qualitative data to see what our patients are feeling about the transition clinic, and if they have ideas how to make it better. A lot of my best ideas come straight from asking them, what do you want? What do you need? What do you think would work? So,
absolutely.
Yeah.
Great. Well, I'm going to hop back into the afternoon clinic. So,
well, it was great being with you guys for the hour. I appreciate it. And
thank you so much for joining us. And the 2 presentations just really married together really, really well. Sometime, Brandy, we'll have to, Megan Teed from Milwaukee from the Complex Care Clinic, you would really enjoy a conversation with her. You are very similar. She is just a go-getter and really has a really clear vision for what it looks like in their facility and in their organization. She doesn't have as much support from her organization that you do, and she's continuing to work on trying to build that. So you could be a really great influence for her to learn some more about that. I bet she'd love to hear from you how you did that at Emory.
That'd be great. And I think especially if she has some, in our institution, we have what we label as nursing scientists. Oh, and I'm going to be 20% nursing scientist to help mentor other nurses too. So,
that 150% of you?
Right, on 0.8% salary.
And aren't they lucky?
Right. I think part of it too might be if she has nursing scientists in her institution, if she could get some metrics going on how to measure what she's doing, and even measure what her influential people in her hospital think are needed, can sometimes be a way to move things along as well. So
Yeah, so I think that's definitely, there is some institutional support where she's at, but
mhm.
I just think it hasn't gotten to the level that is probably helpful for really instituting it, you know.
Right. No,
in
it's
a bigger
hard.
program.
And my hospital system as a whole is not as far as we are. And it's
Right.
me constantly pushing, saying it's not enough. And sometimes it's our higher up saying everything's fine. You guys are figuring it out. Why do you need more help? So
Yeah,
um,
very good.
yeah. All right. Well, thank you so much.
Yep, have a great day. You guys have a great weekend.
Day. Bye-bye.
All right.
Bye-bye. Bye,
Beth,
Judy.
everything went well, so have a good day, okay?
You too. Bye. Bye, everybody.